Good afternoon. Welcome to Her Dignity Network's webinar on a sustainable model for reducing maternal mortality, evidence from the SHARE project in Sub-Himalayan India with Dr. Jameela George. My name is Paige Cunningham, and I'm the Executive Director of the Center for Bioethics and Human Dignity, a Christian bioethics research center at Trinity International University. And the webinar today is part of our initiative in global women's health and an 18-month campaign on maternal mortality. And this webinar is our third in a series of 4. It is my pleasure to introduce Dr. George, who is a medical doctor with years of experience in community health and development. She has been a pioneer in many projects with the Emmanuel Hospital Association, the largest network of non-government hospitals in India. And Dr. George founded the Center for Bioethics in India, the first of its kind. It is the Christian voice on ethical issues in India. And she was also a director of the SHARE project that she will be telling us about. I first met Dr. George in 2009 when she studied as a Global Bioethics Education Initiative Scholar here at the center. Our friendship has grown since then. I had the opportunity to teach with Jameela in India in 2011, and she helped us launch Her Dignity Network in March of 2013. Jameela is a woman of great strength, admirable determination, insightful skill, and vibrant Christian faith. And I'm looking forward to her presentation. Now, you may have connected with us through Her Dignity Network. The network is the online vehicle for our initiative in global women's health, and you will see the website address on your screen later in the webinar. Her Dignity Network connects people and organizations from around the world who share 2 basic ideas. First, that women's dignity is human dignity. And second, that the bodies and health of women and girls are essential both to their human dignity and our common humanity. No one woman or girl should be discriminated against or exploited because she is female. Whether she's a widow in India, an unborn girl in China, or a woman with disabilities in Kenya. And that's what Her Dignity Network intends to change. We want to protect all of her health for all of her life. Before we begin our presentation, I would like to invite you to submit any of your questions as they come to mind, and you can simply use the Q&A box on your screen. We look forward to having time of discussion at the end of Dr. George's presentation. And now, let's hear from Dr. Jameela George.
Today's topic is about a sustainable model for reducing maternal mortality in Sub-Himalayan range. I had the opportunity to work in that area since 1998, and as I worked in that area, which is very mountainous, roads are scarce, people live in these mountains. We came across a lot of people with maternal mortality. Now, India has a population of 1.23 billion. So I'm sure you understand that there are a lot of babies born. And each baby represents a maternal mother, a mother who gives birth to the baby. And this has been a vital problem of having maternal mortality in our country. Now, when we say maternal mortality, it is tragic that too often maternal deaths are not visible. They don't leave any trace behind, and their deaths are not accounted for. In cultures where maternal mortality occurs so often, people just move on. Men get married to new people, and the death of a mother is totally forgotten. Now, maternal death is defined as the number of women who die during pregnancy or within 42 days of the termination of the pregnancy. When we say pregnancy termination, it could be an abortion or it could be a full-term delivery. Now, the maternal mortality rate is the annual number of female deaths per 100,000 live births from any cause related to or aggravated by pregnancy or its management. Of course, it excludes accidental deaths. So when we say maternal mortality rate, this includes deaths during pregnancy, during childbirth, or within 42 days of termination of pregnancy, irrespective of the duration and site of the pregnancy for a specified year. Now, as we look into statistics, it's awful, I would say. India has about 300 maternal deaths for every 100,000 live births. When you say this is the average, the highest one is you see in Uttar Pradesh. It's a very populous area. We have more than 500. And then we have other areas like Central India, or North India, where these rates are really high. And we have places like Kerala, where it is quite low. But then it is so different that the maternal mortality in India, we don't have proper figures. So these are estimates and not actual figures, as you see in some of the other countries. Now, in the year 2010, we had about 57,000 maternal deaths. And this is about 150 dying every day, which translates to 6 every hour or 1 every 10 minutes. This is maternal death. The current estimate is that it is about 80,000 a year. So this is very tragic because each death, as you know, has its own repercussions in families, the loss, and a whole lot of things it affects with each maternal death. Now we may think that maternal deaths are so many, so what are the causes? To begin with, we will see the medical causes of maternal mortality. Now we know that hemorrhage plays an important part, whether it is during the time of pregnancy or after delivery. Now, whatever the cause, when there is too much bleeding and there is not enough blood available to replace and to do the needful, these end in maternal mortality. And an underlying thing is anemia. Now it is said that about 58% of mothers are anemic in India. So what it means is their initial status of blood in their body is less, and then when they have this bleeding, they are more prone to have a maternal death. Now, ectopic pregnancy, sepsis, eclampsia, all these can cause maternal deaths. Another important thing is abortion. Now, there is an estimate that we have about 11 million abortions per year, and 2/3 are unsafe abortions, which means that they are not having it in a sterile place like a hospital. And it is estimated that actually it's not 2,000, it's 20,000 young mothers have unsafe abortions each year. So out of the 80,000 maternal mortality, that we have, maternal deaths that we have, 80,000, 20,000 are from unsafe abortions. Now there are different causes, but research has come to the conclusion that these could be the main ones. Delay in decision making at household level, lack of transport to reach a hospital where they can be dealt with, or delays at the health care facility. Now when we say delay in decision making, most of the deliveries in the rural areas are in homes. So if somebody needs a hospitalization and intervention, decision has to be made to take the person to the hospital. So there is a lot of delay. Who decides? When is the decision made? And how do they react to that? Then they have a lack of transport, taking the person to the appropriate places. And in the health facility also, if they do not have the required technology to be able to intervene, or the doctor, a gynecologist, an obstetrician, to do the needful, then from that health facility they'll be referred to another facility. And, so by the time they reach the hospital, or before they reach the hospital, the maternal death occurs. And we see a little more. Another cause is child marriage. In India, there are children who are married even at the age of 4 or 5. But of course, they don't live with that husband so early. But India has 40% of the world's child marriages. And we have specific places like Rajasthan where that is the norm. So in 2001, it was found that we have 1,500,000 girls below the age of 15 who are married. Now that is a very large number. And out of them, about 300,000 girls are mothers. So at such a very young age, they have gone through this whole episode of becoming a mother, and many girls lose their lives. When they have this early pregnancy, as we know that the body is not yet ready to take up this burden, and the pregnancy leading on to delivery is very traumatizing, and there is every opportunity for these young girls to die. Now, when they are married so early, there is lack of spacing. So you see them becoming pregnant over and over again. And there is no time to recuperate from the first pregnancy and lactation and all that. They're pregnant again. So there is high birth rate also. All these things clubbed with malnutrition and existing anemia take their toll. The mothers lose their lives. Underlying these things is the low status of women in countries like India. So this discrimination against girls is actually, they find their, pronounced presence even before the child is born. So if you know that is a child, a girl, then you have female feticide. And then you have the female infanticide. And when the children are born, the girl child is not fed or breastfed as a boy would be. So less food and inadequate medical help when they are ill. If it's a boy, they'll rush to the hospital and do everything possible to, take care of the boy. But when it is a girl, it is neglected. Similarly, female literacy. So illiteracy also contributes. They're not literate, they don't go to school, they're given in marriage early, and a low socioeconomic status is a deterrent, actually. These things are pronounced, and they are more in the rural areas in India. India is predominantly rural, so when you say it's more there, it's quite pronounced. Now, location and topography of that area also matters a lot. Now, in that share project where I was working in the Sub-Himalayan regions, the villages were on the slopes of the mountains, as you see, or on top of the mountains or in the valleys. And I'm sure you can notice that there is no road anywhere there. So, medical facilities do not exist. Medical facilities, healthcare centers are very, very far away. So if anyone is sick, it's extremely difficult to get them to the hospital on time. So accessibility and transportation is a problem. And these villages are very small. Sometimes you have, just hundreds of people living there, or 1,000, and they're far apart. They have their own cultural beliefs and their attitudes that they don't really used to bother about what's happening in the next house or to offer any help. Each one would take care of themselves. So these were the presenting situations when I was working in that area. So the government, of course, is doing its best, trying to intervene to help with the Millennium Development Goal to decrease the maternal mortality by 3/4. It has been doing a great job to improve the hospital facilities, to see to it that more healthcare professionals are working in these hospitals, and really help the people and educate them to increase institutional deliveries. Because we know that about 10 to 15% of the deliveries will need hospitalization and medical intervention. Now, in order to facilitate it, we have what we call the ASHAs, Accredited Social Health Activists. These are trained in thousands all over the country to educate the women to go and have their regular antenatal checkups, to do the needful, and to escort them to the health centers where they can have safe deliveries. So this has been a great move forward from the side of the government to bring down maternal mortality rate. Now, as I was working in SHARE project, thinking through some of these issues, it was becoming very evident that we should develop something local, something appropriate, something which would be cost effective and sustainable, so that even if we would move away from that area, the people there would be able to take care of themselves and do the needful, so that we could reduce maternal mortality. So it is with this in view that we started the emergency referral system. Now, SHARE project was started in 1985 by Dr. Ted Lancaster to make health for all a reality. The villages that we were serving through SHARE project were about 25 to 75 kilometers from Mussoorie, which is a very beautiful city on top of a mountain. So these villages are scattered on the mountain tops or valleys. They are without roads. They're far away from medical facilities available from Mussoorie. So as we sat with these numbers year after year, trying to see the maternal mortality and the infant mortality that was going on in that area, we came up with this emergency referral system. We had discussions with people to identify all the key stakeholders to see what we should do to bring those living in these mountains to medical facilities at the appropriate time, so that they would be able to deliver there and get the necessary intervention. So in order to do that, we identified a number of issues. That the awareness of people living in those hilltops were very limited. And we also came to know that in an emergency, there was no way to get these people across these mountains to the hospital. There were a few jeeps in which people would travel. They were, of course, owned by people who lived in their own villages or in the hilltops. So in an emergency, it was very difficult to get hold of a jeep to transport a mother who is undergoing, pains, to take her to the hospital. The other thing we noticed is that the traditional birth attendants, who were the midwives, of the local area had very limited knowledge about how the uterus was or how the baby was inside. They thought that the stomach, which, gets all the food that we eat, and the uterus was one big barrel inside. So during pregnancy, they would tell them not to eat certain food. Or even after pregnancy, they thought all the food would go and, infect the uterus from where the placenta has been detached. So they had all sorts of ideas. And so we found that it was very necessary to give them the necessary knowledge to understand. And they had a common idea that they could deliver any baby at any time. They did not think that they were limited in their ability and that there were conditions for which a little more knowledge and intervention was required. So we identified that these were the needs in the places. And of course, the hospitals said the people are not coming. And the people had their own difficulties reaching the hospitals. So keeping all these things in mind, we started the awareness meetings to create awareness in the villages in order to give them the ability to discern when and at what stage they should make a decision, either they should go or not. We had a video, a DVD, which was called Purna Viram. This was an excellent tool. We went to these mountains without roads, so we had to take everything on mules, even the generator and the TV. There were no LCD projectors in those days. TV and the kerosene and everything on mules, and our musical equipments and instruments, and to go ahead to set up a stage and then go around the villages informing, with a drum or something to collect the people to come for this particular event. And we made sure that the decision makers of the village would be there, and we gave them a prominent position in that awareness meeting. Now, in the awareness meeting, we screened this particular film. Now, this film is about a lady from a rural area who was pregnant, who was not able to go to the hospital for regular checkups, and her husband was a person under alcoholic influence. So this lady did not receive all the care and, the tetanus toxoid and the tablets and all these things. And when she went into labor, her husband was far away, and this lady who was taking care of the delivery kept on saying that this delivery will take place. She'll be all right. She needs a little more time. This was the first delivery. And, in those villages, it was very dark and difficult, and ultimately, this lady died. So this particular story captures all the different things which could have prevented this lady from, dying. And it was not at all difficult for the people to understand that, because they could identify this whole process going on in their communities over and over again. Now, with these people, we then asked people to volunteer and made youth groups of volunteers who would be willing to go to the nearest places where the jeep could be found if there was a need to transport a lady. So we had these volunteer groups all over the place. And the next thing was to educate the people through these events and give them all the needed understanding of why they need to take these people to hospitals if there is a need. Now, volunteer groups were formed in these places, and they were motivated to become effective in their villages. So the only job they had to do is, whenever there was a lady in real distress, they had to run to a nearby village and bring a person who had a jeep to transport. Now we had a problem there too. The jeep drivers were very few. There were only few jeeps. So when there was an emergency, they would ask to be paid sometimes twice the amount or sometimes thrice if it was a night. So then we made a plan. We had meetings for these jeep drivers. We invited them at strategic locations and had a lot of discussions with them. And we imparted, the value of life. And then we said that you're doing a great job if you would come when you're really needed and do this, transporting this lady from the, place to the hospital at a normal rate. So at any point, you're not losing anything, but you're not exploiting the situation. And that, they willingly accepted. And we said, it's only once in a way you have to do this. It's not all the time. These villages are so small. So maybe once a year or once in 2 years, and that's not a great thing. And they said, yeah, it's not a great thing. We can very well do it. So we had all these jeep drivers willing to, transport the people whenever they are needed. And at the other end, we had very good rapport with the hospital. And we interacted with them. And when we said, whenever people come like this from all these areas, just admit them and do whatever is best for the lady and the child. And we would do the rest. Sometimes some hospitals would feel that, they may not pay for it or, they need blood and this and that. So it was sort of educating the whole chain of events through the people with the existing things, and it was all coming together. Now here you find a staff educating the traditional birth attendants, the midwives. As I told you, they thought that everything's a barrel inside and they had a tough time understanding. So we used models and, fetal models and showed them how the uterus is. They were so excited to see how it was inside. And these fetal models so nice and the uterus and, coming out and all that stuff. And I had to go from place to place doing this with slides and things and showing them that how there are possibilities of a twin or a lockjaw or a true knot or this or that, by which the cephalopelvic disproportion or whatever the cause is, that the child would not come out and so needed intervention. So once they understood that, they knew that they are limited in what they should attempt to do, and they should know that well. They were very eager to learn. So we had a good job. We could have a very good interactive time with these women, and they were ready to learn, ready to be taught. So we had a lot of joy in teaching these women who are right there, and to equip them, give them the necessary skills and abilities so that they would be able to cater to the needs of the people there. Of course, we had some evaluation of these traditional birth attendants. We also had the community health volunteers. Most of them are uneducated or very little educated. So we had to repeatedly teach them. But they had a way of understanding and being able to remember the vital things. And we used to grade them and help them and retrain them so that they would be good in their job. Now, as I say, I found it very necessary to educate the different sections of the society regarding a particular thing. Now, what I mean to say is, we had the awareness meeting where the whole village was there, young and old. And then we used to teach the community health volunteers. Then we had women's groups. So we taught them there also. Because one important thing was the value that we need to respect life and that we need to help one another. Only then the system would work. So we taught the adolescent groups, and we had, at that point, about 1,600 adolescents, boys and girls, in our program. And for these girls, we even administered injection tetanus toxoid. We dewormed them and then gave iron and folic acid to build up their hemoglobin level. And along with that went the teaching. This is the one who's sitting down here is a nurse who's teaching them, helping them. They're very shy people, but anyway, over a period of time, they were really good. They understood all these things. And to begin with, they said, we don't have any worms in our bellies. I mean, what is that? And then when they had these tablets, and out came a roundworm. They came back to us and said, I think we don't know, maybe someone is hiding somewhere or something, please give me some more. So that was a good way of getting rid of these and then teaching them hygiene and then, building them up. So all these are part of this. Then we felt that we need to strengthen the linkages. What I mean is, we taught them, we did this, and we went through this. We saw the fruit of it. We saw how these maternal mortality was coming down. So that was a great encouragement. And we saw how this referral system was working, people bringing. And whenever such a patient would reach the hospital, we would be informed. So sometimes it was too much bleeding, sometimes there was a miscarriage or whatever, but then the mother was saved. So they saw, okay, such condition earlier would have resulted in the death of the mother, but now by this method, it's working and they are not dying. So we, went over that again and again so that as to reinforce this whole concept and that it would become part of that. And it also spilled on to the other things around. In one particular village, a person had terrible abdominal pain. So he was a man with abdominal pain. But then the youth of that village felt that, we can use the same, they call it emergency. They don't understand because it's an English word and they translate it, getting them to the hospital. And this particular man was all by himself. That was not his village. His village is far away. So the youth group there collected money from the other people and got a jeep, transported him to the hospital. It turned to be an appendicitis. The doctors had to perform an operation just on time, and the project helped. And the hospital also gave a charity towards this, and the man was saved in that manner. So this, as you see here, you see these trees which are very tall from the mountains. The women and people, climb on these trees, which are so dangerous. And they take the dried wood from there. Time and again they fall down, break their ribs. And then this emergency referral thing brings them to the hospital. So apart from, taking care of the maternal mortality, it was useful in other ways too. So as we have seen earlier, the volunteer groups, training, and all that, we evaluated this again and again and strengthened the linkages. Now, what are the real advantages of such a thing? It helped us to identify locally available resources. The traditional birth attendants, the jeep owners, the hospital which was there somewhere, and it really facilitated change in attitude. That was the main thing, I would say, because everything was there, but then we had to just link them all together, and they began to care. If somebody was sick, somebody was in danger, somebody had some need, they would volunteer and get together and do the needful. And the village headmen and all those people also knew that this is a good method. So they became more confident and they could entrust us, saying that the birth attendant would do her needful and so on. So it improved their capacities, it improved their confidence and so on. And it brought the community together so that they would get together and do something for a common good and for individual good. So this is a very sustainable model because we are not investing in anything there apart from being catalyst and helping them understand and put into practice what they can do. with the limited resources that they have, in spite of the mountains that I showed you. And this brought down the maternal mortality in that area. It also, when you say maternal mortality, it also helped to bring down infant mortality, neonatal mortality. And it was wonderful to see that taking shape and coming to fruition. Now, SHARE project was working in this area for many years, and when all these things were set up, not only to reduce maternal mortality, but to bring up literacy level, to have a lot of toilets being built and water brought from different mountains to the villages, it became necessary to move on, to leave the people to take care of themselves in that area and to move on. So now SHARE project is working in Bijnor in UP, which is a highly populated area, and there are a lot of births going on and maternal mortality too. Now here, time and again, we find stories of women dying in this area. Most of the time, it is due to bleeding, excessive bleeding at the time of delivery or soon after, and before they reach the hospital, they die. We have so many stories that show us very clearly that this place too needs this emergency referral system in place. Now, sometimes the patients need a cesarean section, and sometimes the patients go to local practitioners who are not, educated healthcare professionals. And the misuse of oxytocin, they end up in a ruptured uterus, things like that. So this place is so remote that you don't have good medical facilities close by. So we see that there is an important work to be done in this place, and SHARE project is now involved in empowering women through the 80 community-based organizations they have. So equipping them, giving awareness, helping them. And they're also attempting to train the technical groups, the auxiliary nurse midwives, the accredited social health activists, the Anganwadi workers, and the rural healthcare providers. So they are involved in building up the team, setting the stage to move on to developing the emergency referral system. It's not easy because you need a lot of resources, and that is a real challenge. Both financial and human resources are needed to do this in multiple places and to bring this awareness and the whole thing. So this is the SHARE team which is currently working there, eager to work, they're hardworking, and they are involved in this, bringing maternal mortality down, and they have very good networks with the government hospitals and other hospitals and mission centers. And it's my privilege to share with you the story today and to say how the people living in such remote areas where facilities are limited can be helped to stand on their own feet and to take care of themselves, provided we give the input and increase their awareness so that they can do their best. Thank you.
Thank you, Jameela, Dr. George. I was so excited about the second story. When you were talking about how this SHARE model is sustainable in Uttar Pradesh, the very populous area, it seems like they had different needs to build their emergency referral system, and you showed different responses to that. How how could this method be used in other places? Like, could it be useful outside of India?
Oh, it can be useful anywhere in the globe where there are very few facilities available, and for most part of the places where they don't have anything. So there is always opportunity, especially in rural areas, because in India, all the hospitals, most of them are in the urban areas, so the rural areas are less. So this will be brilliant in any part of subcontinent or Africa or wherever we have limited medical resources available, so that they can link up the people with the hospitals with the available things, so that they will be sustainable. So this works wonderfully. It's, I mean, as you think about it now, it is like common sense. You need to link them and you do it. But to begin with, it was a new concept, and then we found a lot of joy in getting that done.
Well, I want to invite the rest of you to join the conversation with Dr. George and type your questions into the Q&A section on your screen. And I'm going to start add another question to that. In terms of the model, it seems like, at least here in the West, we want to do things very quickly. And we would like to have sort of some simple solution for reducing maternal mortality. How long does the SHARE project typically take? And do you see that as being more effective than just sort of coming in with a new drug? Say to stop the bleeding.
Yeah, stop the bleeding. See, the problem is you may have many drugs and things, but they don't reach the people. So that's the main thing. You may be developing new drugs for everything, but then it will not reach the people, the mothers who need it. So we see that to begin with, this is a little slow model. But then once they see this doing in one village, others learn, and it spreads around. So we're sick, but then they did like this, and then their stories go on. And so while I say that it is good to have new drugs and new things, the main problem here is that they can't access what is even available now. And so newer things will not reach them.
So we really need both. Another question is the SHARE project still going on in India? And if somebody wanted to get involved, what could they do? What does the SHARE project need now?
Yeah, the SHARE project is very much there in India. It is in UP, in Sihora. At this particular place, the terrain is different. It's more of plains. But then we have a very large Muslim population and a lot of children, being born. And these families have a lot of children. So there's maternal, deliveries happening all the time. So the need here is also to educate them, to help them understand even spacing methods and things like that, and to equip them with the knowledge and the attitude to refer them to the hospitals. So if somebody wants to, visit that place, they are most welcome, or to volunteer to work there for a while, that's great. But we'll need some Hindi, because that's the language of the people there. And if somebody wants to, see it for themselves before they take it to elsewhere in other parts of the world, that's fine. If somebody wants to contribute something towards this work, that's great. So, and you can, encourage these people who are in such remote areas to carry on.
So I think the encouragement could be a really big part of it. And just for the listeners or viewers, I should say, we do have information about the SHARE project on Her Dignity website, and there'll be a slide on that at the very end. But just to let you know, if you do want to find out more about the project or the method, or contact Dr. George, all that information is on the website through a fact sheet that you can access on the website. So if you go to herdignity.net and follow the webinar link for today, the fact sheet is there on the webinar page. So I just want to make sure you're all aware of that. So we have time for maybe a couple more questions. and then we will wrap up in just a few minutes here. But I want to make sure everybody who wanted to ask a question has a chance to get involved. Another question is, do you do anything regarding spiritual care? Is this a faith-based project? How does that work in terms of working with the government?
No, we are a faith-based organization. The government is very well aware of it. But that doesn't mean that we are going to impose our views on the people. Because of this faith, only people are working in such remote areas where others are not found. In fact, in that area, there's no other non-government organization working. So it's a very needy area. And unless we have faith, we won't work there because it's not easy. It's tough working there. Yeah. But then if somebody asks, no, why have you come? They've asked me this question. They know that, we're not from that area. We come all the way from somewhere. Why did you come here? What made you come and work here? Then we get an opportunity to share, to say, I'm a Christian and I believe that all human beings are valuable and I need to use my talents and my ability in the medical field and use it where it is needed, not in cities from where I come from. But we need to be here where you need us. And so that has given us an opportunity to share about it.
Okay, and one last question. Are there other projects in India, other share projects, or where would be the next place that they might go to help reduce maternal mortality?
See, this place they have just moved a couple of years back. There's a lot of work to do. So unless they do that, they cannot move. They need the resources to establish this and to help. Now, along with this, we have volunteers being helped, taught, so that their capacity is also built from these communities in all these health issues. So it's building a whole cadre of people who will be able to keep doing all these things. And apart from maternal mortality, they have a whole lot of problems like tuberculosis and people who are disabled, how you help them. So there are different projects in the same community that we have to do in order to meet the various needs in that community.
Well, it's very exciting how you're taking the whole community and sort of the multiplication of what you're doing. And as an educator, I think about what we call transferability, where you told the story of them helping a man using the same system because they're saying, oh, it works for women who are having trouble with their delivery. It can work for a man who is very, very sick. So I really see that as a very holistic and life-affirming kind of project, that it really helps the community to flourish as a community, not just the individuals. And that's one of the reasons that at Her Dignity Network, we're very excited about the SHARE project. And so I wanted to right now thank Dr. George for your time in sharing about the SHARE project and being with us. We actually get to have her here with us on the Deerfield campus of Trinity International University, where the Center for Bioethics and Human Dignity is located. So often we have to communicate via technology, so this is a real treat for us. And for our viewers, if you would like to get involved or find out more about the SHARE project, as I mentioned before, you can access a fact sheet through the Her Dignity Network website. And one of the things that we know they need is prayer, above and beyond everything else. And there may be other ways that you can get involved and maybe observe the project to take it to your own community. And so we just invite you to take some time to consider being involved in this way. We don't endorse many projects through the network, and this is one that you can have confidence in supporting, that they affirm and protect human life at all stages from conception through the end of life, and they're very careful to protect and respect human life. I have one brief announcement, but first, please join me in thanking Dr. George. If we could all clap, at least virtually. Some of you may have the little applause emoticon, but thank you so much for being with us, Dr. George. In closing, I wanted to let you know about our fourth and final webinar in the maternal mortality campaign. Dr. Monique Chereau, an OB-GYN who also teaches at Duke Medical School, will be joining us sometime this fall, and you will get an email announcement when we can confirm the details. So if you see something coming from Jennifer McVeigh or Her Dignity Network, don't discard it, but pay attention because it's probably the announcement about the next webinar coming up this fall. And also, if you would like to join Her Dignity Network, it's free. You just sign up on the website on the members link and join the growing list of members from around the world. And we will put your first name and your city on the website. And we hope to just see many more names added to that list from people around the world who really care about the health and bodies and dignity of women and girls around the world. So again, thank you for joining us today, and we hope to see you next time.